Good morning, and welcome to another episode of Issues That Matter. And I enter this episode with a little bit of regret because I've enjoyed having the guests that I've had related to suicide prevention on for the past 5 weeks, and it's hard to believe that 5 weeks have passed already. But welcome, and I know we're going to finish off this series with the gangbang show, a wang bang show. And so to start the show, let me reintroduce my guest co-host.
Hi. Nice to see you again.
Catherine Zwickett. Welcome back.
Thanks. Thank you very much. You had a break from me last week with Emily Weston and other folks.
In some arenas, they might call it a break. I would call it deprivation.
You're a cheerful liar.
In any event, Catherine, why don't you introduce our guests?
Great. Thank you so much. Well, I'm very pleased to reintroduce Greg Marley, who is the clinical director for the National Alliance on Mental Illness Maine chapter, and is also our suicide prevention training partner for the state of Maine. And Jamie Ream is the clinical supervisor,
case management supervisor.
Thank you. Case management supervisor for Sweetser, and is also a member of our advisory board for Maine Suicide Prevention Program. And today, as you said, 5 weeks has gone fast. Back in July, I thought, I got plenty of time to put this all together. And here we are.
July was when we first had a conversation about doing something on the show.
Yeah.
And it seems like it was just yesterday.
Yeah. It's been wonderful. As I said, I think it's been great. Greg's been here 2 or 3 times.
Twice.
And just to be able to raise awareness about all the good things that are going on around the state of Maine and suicide prevention, and providing opportunities for our partners to shine light on what they're doing.
Interestingly enough, maybe it's because my level of sensitivity is heightened, but I spend a good amount of time on the web. Issues That Matter has a Facebook page on the web. And one of the things that's been slapping me in the face with a certain degree of frequency these days is the people that are out there that are concerned about suicide. I think it's something that we might have been a little bit reluctant to bring up in the past, and I might have been blind to it because I didn't see it, but I sense a heightened awareness. And I know it's not because of the show, because these are people that will not have seen the show. They live
right.
all around the world, all around the country. But there's a heightened awareness, and I think it might be a function of the complex society that we live in today. I mean, the dealing in today's world is significantly more complex than it was 25, 30, 40, 50 years ago. Well, and I'm not going to go back any further than that.
Thank you. I appreciate that. I think you're absolutely right. When we started this work 20 years ago, there was this hesitancy to talk about suicide prevention, just like it was difficult to talk about the birds and the bees. But we learned and understand that while it is not an easy subject, that conversations do have to be had, and that the more people you involve, the more agencies you involve, the more support you have. And I think it's a great segue for what we're talking about today, in that just like we've talked about school systems and their roles and responsibilities, we're now recognizing the critical importance of the healthcare system. And in 2014, members of the Suicide Prevention Program attended its annual grantee meeting as one of our roles and responsibilities to the Substance Abuse Mental Health Services Administration funding. And at that meeting, a gentleman by the name of Dr. Michael Hogan was a keynote speaker. And during his talk, he introduced the concept, if you will, of working towards zero suicide. And that concept is the understanding that those individuals who are in the healthcare system, be it behavioral health or other healthcare professionals who are at risk for suicide or who are in fact in crisis, those suicides can be prevented. And he went on to recognize that many of these folks, sadly, frustratingly, may fall into the cracks because that lack of understanding about suicide, a lack of knowing exactly what to do with individuals who are at risk or in crisis. So we touched upon those roles of healthcare providers, and again, recognizing the healthcare providers can't do it alone. Just like we talked about when we talked about schools.
Yep.
Schools have a role to play, but it's not on the backs of just the schools and the staff. It's all the community. The Working Towards Zero Suicide is focusing on healthcare providers and professionals, keeping the client safe and also keeping the staff safe, because they may be coming into contact with individuals who are maybe violent, are scared, and all kinds of emotions. So during that conference, we brought him back to the state of Maine, Dr. Hogan, to talk and present this Working Towards Suicide at our 2015 conference last May. And from there, we've now gone, and through our advisory council, through our training contract with NAMI, slowly but surely introducing this Working Towards Suicide, recognizing some folks took, I don't know, and you tell me, take offense or were put off by the all suicides are preventable, because that felt very definitive and potentially punishing.
What I have really found, where I've gotten pushback and where I've been very careful to say that suicides are often preventable, is if you have lost someone to suicide, particularly if that loss seemed to come without warning, and then someone says all suicides are preventable, what layer of guilt is laid onto
Absolutely.
your grief? And people have reacted to that. So we have to be careful about how we frame that. Yeah.
And it feels as if that the working towards suicide is something that's tangible. We can work toward it without
Toward
that
zero suicide.
to zero.
Yeah.
Working towards zero suicide. So one of the things, and Greg has a great example of with Ford talking about how that works, and then Jamie for sure, how Sweetser is incorporating this concept, if you will. So with that,
Yeah. So some of this, the real proof that this has been working came out of a large managed care organization in the Midwest. It's called the Henry Ford Healthcare System. And they've got over 200,000 clients in this managed care system. A couple of hospitals, a bunch of outpatient clinics, primary care, the whole range. And they recognized back starting at about the end of the 1990s that they had a problem with suicide. They had a rate of suicide deaths among their group of about 89 per 100,000, which is about 4-5 times higher than the national average at that time. And they said, what can we do about this? And they really started up at the top, the leadership, looking at what are the possibilities, what does the research show, what can we do? And it was a leadership-driven model of making sure that everybody who's covered in this managed care has the access to care through multiple pathways, that they are really focusing on the recognition of and treatment of depression as one of the correlates to suicide. They really worked on adopting evidence-based practices for assessment and for treatment of anxiety, of depression, of suicidality. And then they trained their staff. And they really worked to develop a very competent workforce. And there were 3 other pieces that were vitally important. So they did the assessment, they had multiple pathways to treatment, and then they added making sure that there was safety planning done with anybody who's at risk. Not just put them into a hospital and see what happens, but really clear safety planning, which is done on a collaborative basis, pulling someone's own strengths and resources, their family strengths and resources, as well as the professionals they were involved with. And the last piece of that is to really ensure that someone at risk has a clear follow-up plan. So we're assessing you, we're making recommendations for treatment, we're doing safety planning, and by the way, we want to make sure we see you in 3 days, and then we're going to see you next week, and then we have a plan for following up as well. Knowing that follow-up is so vitally important. Now, what happened really amazed people. almost within the first year of putting this into place, they had a rapid drop in their suicide rates. Over the following 10 years, it was about an 80% drop in the rates of suicide among 200,000 people, including a number of quarters where they had 0 suicides. About a year and a quarter, 0 suicides among 200,000 people. So they're really showing, and there's been some other examples of this as well, that conscious, carefully thought out, across the board planning within a system can rapidly reduce suicides.
And certainly we recognize, the suicide prevention program recognizes that, just like school systems, their communities and systems in and amongst themselves, in and of themselves, healthcare systems are the same way. And just as we've often said, time is such a 4-letter word. And we just recognize that we have to be very methodical and get pieces into place. So Jamie, just a little bit about Sweetser and how that concept that,
Well,
working
many
towards
people
zero.
know Sweetser as a large behavioral health, one of the largest behavioral health organizations in the state. And many people who come to Sweetser are open to receiving services for mental illness or something that they're struggling with. So we've always worked with a group of people who are open to receiving some supportive services. I think about a year and a half or 2 years ago, there was some folks in leadership positions at Sweetser who attended a training in Washington on the Zero Suicide Prevention Council, I believe, in Washington, and really brought back information about it being a goal for Sweetser to work towards a reduction in people who complete a suicide. And so we've done a lot of work internally to make that happen. It's been helpful to have that buy-in from leadership.
Absolutely.
So I think that we are moving in that direction. It's a lofty goal. I don't believe that we've met it yet, but I do think that there have been some things put in place across the organization that will help to meet that goal.
And you said about a year and a half, 2 years, but you've seen a steady, just methodical.
There are internal things that we're working on with client records, with all aspects, sort of like your gatekeeper training, where it's not just the clinicians, not just the therapists who are getting this training, but administrative office staff, because suicide, unfortunately, isn't something that just happens to people who come in for treatment. It happens across all walks of life, unfortunately. And so we're training office staff, and everyone will get the training on things to look for and ways to help people. And we've, along with the national model, we've developed specific pathways and safety planning and some other things that have been evidence-based to work to help reduce those outcomes for folks. So.
How much of an impact in today's world, and this is essentially much more prevalent among the youth of today, they seem to be they're tapping away on their either smartphone or laptop or computer or something, and they're cloistered, you might say. And they're not out there socializing with people. They're not out there with their friends, relieving their anxiety. But they're tapping away on something that, I forget where I'm going with this, but does that have an impact on their ability to deal with the stresses of life
I think
that might feed the problem, you might say?
I think it's always dangerous to refer to social media or the internet in one color. In some ways, it can be isolating and remove people from face-to-face contact. In other ways, it opens up connections with like-minded and supportive people. So it's a both and. What do you think?
Yeah, I was just going to say, I think that the isolation piece for real is a part of sort of a depressed stepping back from interaction, but I wouldn't want to say that it's social media, or it's more the isolation from like-minded people or a supportive community. Some people get that from the internet and other people don't.
The isolation being the risk factor,
Right.
for sure. Yeah.
Is, for example, my son, who's a very social animal, he's 21 now, he went to college, and before he went to college, he didn't do texting. If he wanted to connect with someone, he would call them, he would talk to them, he would try and get together, he would talk to them. He got to college, and he realized if he wanted to have that conversation with somebody, to connect with them, he had to text them. So he started texting, but texting was that vehicle to open up the door for further
Right.
conversation.
Right, right. So in the work that we're doing as a partner with the Working Towards Zero Suicide, I know you have been working a lot of time with Maine General, and that is a huge system, just as Sweetser is a huge system. So a little bit about.
Sure. I'm going to take a step a little bit before that. We know across the state of Maine and across the country, suicide rates really climb through the 20s, where the numbers actually peak around age 50, though the actual rates peak with men in their older years. So there's a lot of people in middle age that are at high risk. And the question always has been, how do you best reach them? They may not come into a mental health treatment program, but they all see their primary care providers. They all are seen in the emergency room. It's a place where people are seen and can be recognized at risk. So there's been an effort to engage in healthcare organizations, both behavioral health, but as well as primary care, physical health. And so as part of that, through the Maine Suicide Prevention Program, NAMI's been working with some healthcare providers. And we started kind of an ongoing effort through one of the medical centers in the state, Maine General Medical Center. And again, we tried to implement elements of this zero suicide factor, which is starting with some leadership-driven protocols. And a protocol, it shows a pathway to accomplish something, reflecting that there's planning and there's forethought that went into it. So we were way back a year and 3 months ago, I did an initial protocol development workshop with a bunch of folks from Maine General Medical Center and some of their practices under their what's called a patient health organization, PHO umbrella. And then we've been working with them to help tailor some of those protocols to the specific practice reality, because one protocol doesn't meet the needs. So that's at one level, leadership driven. And then the second level we've been working with some of the practices to do training. So we started out under their PHO, they have Maine General, Health Reach, primary care practices, as 11 practices across central Maine. And so we started working intensively with 2 of those practices to develop model protocols, to begin training the staff, and to roll out the suicide prevention. And so those protocols have been implemented. We did training with all staff, which is like a 1 to 2 hour awareness session, just like Jamie said for their office staff. And you do that with everybody, the folks that are answering the phones, the folks doing billing, as well as clinical folks. And that kind of talks about the protocol and how to recognize someone at risk. And that works with the idea that if I'm struggling with thoughts of suicide, I may be hesitant to tell my doctor, but I might share that with somebody else who I feel more comfortable with. So a little bit of training for everybody, and then more in-depth clinical-based training to assess suicide and do safety planning and follow-up with the behavioral health clinicians and the nurse practitioners and the osteopathic doctors and the medical doctors. So these 2 practices have implemented it, and now their practices are in a process which should be finished by the end of the year, where they're tailoring those protocols to each of the other 9 practices and doing the staff training to roll it out. It's been maddeningly slow, and but very effective. And then the larger system of the Maine General Medical Center is continuing to develop protocols for some of their other practice and coverage. We're hearing great things. I've talked to a number of providers already who said, after the training, they're more comfortable, they feel like they have more of a process and plan, and some of this has been very successful in terms of identifying people at risk.
And I think that's wonderful because I think for many people, there's still a stigma in going for mental health
yep.
support, where the statistics show that the majority of people who have completed a suicide have seen their primary care within the previous 30 days.
Right.
That there is a connection between pain and suicide, the
Right.
completion of a suicide. So many people are seeking health care, but not necessarily mental health care, and helping primary care practices sort of tease out that depression and some other things is really, really helpful. Where it's
Absolutely. Because I think as we face with schools and staff were saying, please don't put anything more on our plates. And we're saying, but wait, we've got this really great idea about Gatekeeper and lifelines, et cetera. And I think and wonder if that similar philosophy or angst was felt initially, and I know, I kind of know the answer to that, the working towards zero suicide. So what were some of the challenges, Jamie?
I think some of the challenges have been around figuring out how to identify folks, because we work with our whole population
Right.
has some struggles that they've
Right.
identified to
Yep.
bring them in. So how do we identify someone who has a history of depression to say that it's risen to a higher level of need? So there were clinical discussions about how we identify folks. Secondly, I think it was a technical piece. Once we identify them, how do we identify it in the electronic record? And how do we make sure that that's accurate and that everyone, or is it a need to know? Does everyone need to know that someone's been identified to be on this pathway or not? And then I think the third piece has been, how do we know that they are ready to come off? Or are they
Right.
always on? Or so there have been clinical discussions, administrative discussions, client record discussions. So I think the challenges have been in trying to include everyone who needs to be included,
Right.
and sort of working through the process without a real person or group of people, but more of an administrative oversight of how we're helping a broad base of.
Because I'm sure that there's probably this assumption within a be it a behavioral health, mental health facility, agency, that, geez, you should be able to do this. This should be, and you really can't do that because there are so many different pieces that play into being at risk or in suicidal crisis, that you can't just assume that because someone is depressed or not depressed that they're this or that. So it's taking that time to tease out all of those things. Did you find that similar kinds of?
Yeah, there's several levels of that. The first and probably the biggest level is, boy, primary care gets everything heaped on their plate right now.
Yeah.
And they are so stressed and stretched thin. So we're asking them to engage in this and, on top of everything else. Now, everybody has been engaged and interested in lowering risk of suicide. That's the easy part, but it's the how that's hard.
Yeah.
And a piece of it is, knowing that people come in and they may be struggling and they're not saying, I'm really depressed or I have a high anxiety, but they may be coming up in with body complaints that are related to that. And so one of the things that we're trying to hook onto is primary care practices are working to do regular screening for depression. They use this simple questionnaire called the Patient Health Questionnaire. And so how do you take that PHQ, they call it, and use that as the little flag that says, wow, we need to then follow up and do more screening around potential for suicide. because that can identify depression, it can identify thoughts of suicide, and then you need to assess. So it's putting the elements in place in a busy practice. And as Jamie said, a piece of that is how do you flag someone's chart?
Right.
Right.
And then if someone is assessed and seen at risk and then hospitalized, how do you ensure that when they're released from a hospital that you're following up with them? That's that follow-up piece. Because sometimes we say, whew, boy, we caught that one. We sent them to
Yeah.
the hospital.
Right.
We're done. But then they're going to come back to your program.
And the highest risk is post-hospitalization, the first week after someone's been hospitalized psychiatrically or for depression, not necessarily for a physical health complaint, but if they've been hospitalized for depression, their most vulnerable time is in the week right after they've been discharged. And the research shows that. So having a good aftercare plan, not you'll meet with a therapist or someone a week from now or 10 days, here's some medication, go home, and
Right.
but really connecting all of the team, the family, and
And it does, it reinforces, because I think oftentimes, again, I keep harkening back to the schools because we've done years of work with them, is I'll do my part, I being the school and the staff, but please don't expect it to be on us. And just taking down that mystique and the fear factor of, you want me to do what about what, and saying, okay, we provide awareness to you as a school, we provide awareness and gatekeeper to you in the mental health and behavioral health fields, but we're not going to leave you there. Here are the supports within the communities, and working hard to opening those doors, because not that many years ago, schools felt that they're supposed to handle all of this on their own, and that part of that was just send them somewhere, just send someone who's at risk or in crisis, like you said, get them out the door. And now we're realizing that that's not enough. It's got to take that whole effort, that whole community and state. But again, just saying, you don't have to do it all, Maine General or Sweetser, just take this piece and then we'll keep working on these pieces.
And I think one of the things that's been really valuable recently, just like we're now getting more mental health trained clinicians in schools, we're integrating the behavioral health, the mental health component into
Right.
primary practices, and in some cases doing behavioral health homes where we're integrating the physical health components into a mental health setting,
Yeah.
so that there's easier crossover of information and speciality.
Yeah.
there's easier crossover and there's more comfort level, I think, generally with asking the hard questions, with people saying, are you depressed? Are you feeling suicidal? Do you have a plan? What would that plan be? Do you have means to a plan? Those are hard questions, even for seasoned clinicians, even
Right.
for people who have been doing the work for a long time, to ask those very specific and very direct questions, because what happens if they say yes?
Yes.
And then what do I do? And where do I sit with that in schools? I think anyone who works that in depth with folks and has to ask the hard questions also has to know what the plan is if the answer is yes. And so putting all of the pieces in place, even for an organization that deals with
Yep.
mental health or physical health, those are the pieces that have to come along and work together.
And change is hard. Change is a four-letter word, usually.
No.
But it's incremental. I mean, people, as I said, when we started this 20 years ago, we were taking some hits about the length of time and why aren't we seeing the numbers decrease in suicide, and why aren't we working directly with kids? And it doesn't work that way. We have to safely prepare those folks who are going to be working with, be it youth or an older adult, so they feel as comfortable as possible. It's never easy, but linking them to outside resources, not, and it's time. It does take time, and we all get. I'm guessing I can speak. We all get frustrated. We want to be able to, particularly when we know what we think is the right thing to do. It's just not everybody's on board at the same time. But I think it feels as if we're moving steadily and being successful. Are you feeling there's a level of success?
I feel reassured that there's a level of commitment and moving
good point.
moving
Good
toward
point.
success.
Yeah.
I think for me and others have spoken to the need for buy-in from leadership, and I feel that Sweetser has done a good job with that in moving this forward, that it's not just a problem for the crisis department, that it's something that we all carry, because sometimes frontline case managers see people differently and can get people to a crisis unit
Right.
or for some additional support in ways that, you know, we all need to work together for the same outcome.
And I think this work oftentimes starts out with someone who has deep feelings for it. Our champions, we call them.
Yeah.
And you know, at Maine General, I've been working with two really wonderful champions who are social workers in the practices, Leslie Ofkin up in Bethel and Louise Gephardt in Richmond. But also at the leadership level, Jody Beck, you know, who oversees the quality initiatives, has been very much supportive of this. So you start out with the champions, and then you try and build so that the system is embracing it, and that's kind of, it's a stepwise process.
And I think too for us, time is always a challenge. Capacity and those kinds of things are always an ongoing challenge. But I think for sure the way we've approached this has been very methodical. I mean, you've worked with Maine General, like, as you said, for over a year, and we're making inroads, good inroads, that aren't going to go away. Whereas, and the same with Sweetser. In the last year and a half, people are feeling a level of comfort, a level of assurance and knowledge, and rather than thou shalt do this, it starts from the top, and the bottom is buying in. You know, the frontline folks are saying, oh, okay, all right, we are all on the same page, and we are feeling supported, as opposed to that, well, here's something new, and you're going to do it, and then you wait 6 months and it goes away.
Yeah.
And
And you know that we all look for the quick fix, the pill that will fix things. You know, we're trained to do that in this quick society. But you know, recently we were approached by another large hospital system who said, you know, we're having some struggles here, and we want our clinical staff to have better skills at assessing suicide. And so they asked us to do that, and I said, great, wonderful, and I'm not willing to do only that, because we need to look at the system.
right,
You know, what are you doing in terms of protocols and guaranteeing appropriate referrals, appropriate safety planning, and how are you assuring, if you've let someone out of your hospital, that there's rapid follow-up? So all those pieces in place, and so we're engaging in this conversation about how to do all of that kind of soup to nuts approach.
Right.
Because that's what is, if you're
is
going to move toward zero suicide, those are needed.
Right.
So how is it that when you talk about the safety planning for the client, how does that translate into safety planning for your staff? Be it debriefing, or what are some of those aspects that we talk all the time about taking care of yourself? So how does that work with Maine General and with Sweetser about you as staff taking care of yourself?
I think it comes through supervision, through debriefing, through a process of including as many people on the team. I don't, I don't expect the staff that I work with to make decisions without including me and processing whether someone needs to be referred to a crisis team or not. And then including the crisis team and the hospital perhaps and the family, and sort of working through, it's not one person's decision.
Exactly.
And it's not one person's responsibility to prevent a decision. So,
Exactly.
you know, I think it's more about teaming as a coping mechanism than any one other thing.
That's a good way to put it.
Absolutely. So you're sharing the responsibility and the support across
Right.
multiple people, so that there's not one person that's got all the eggs in that basket.
Right.
And I think that's greatly protective, not only of someone at risk, but also of the health and mental health of the staff.
Right.
And at the same time, we all know the pain that comes if practice loses a patient to suicide.
And
I've
it also increases the level of collaboration
yeah.
Absolutely.
among people.
Yeah.
so that people are not insular, and they're
Right.
reaching out and they're learning the concerns of other people on the team, you might say.
It's the best protective factor on all levels.
That's a
think.
good point. Yeah, because I think there's this assumption that if you work in a mental health field, you get all the answers and you know what to do to take care of yourself.
Maybe you do, I don't.
I'm still waiting. So it's reinforcing, hey, we know the things that we're supposed to be doing, but we're human,
Yeah.
Right.
and with the same vulnerabilities and feelings and whatnot.
And a net isn't a string.
Yeah,
A net is
yep.
people
Yeah.
working together to support.
Now, the healthcare system has been going through some adjustments. I mean, we have a major new health. It's no longer new, but we're working its way through. And there's been consolidation in the healthcare field. What kind of impact is that having on the?
Again, it's an incredibly complex system with a lot of stressors. Some of that consolidation is putting together these kind of accountable care organizations. So in some ways, those are systems of various levels of care, which makes it much more likely, if they have a coordinated protocol and a plan, much more likely that one individual gets the care from people who are coordinating with each other throughout the system, from the outpatient
Right.
to the primary care to potentially hospitalization and afterwards. In that respect, I think it has some positive pieces.
Yeah, I would agree.
You know what I'm thinking about the numbers of the smaller hospitals, the community hospitals that are closing, that are, I would think, which doesn't necessarily mean that it's reality by any stretch, but I would think that in the community hospital you had more of a family sense rather than the big mega hospitals. And with these community hospitals closing, is that impacting the suicide rate, you might say? Because we're no longer, that's one part of the system that people were relying upon that is no longer there.
I think in a state that is as rural as Maine, access to care is and will always be one of our challenges. And the ease of access for someone who's struggling helps to buoy their resilience and support. So I think it's a challenge in that area. But along with some of those community hospitals closing, some of those community hospitals have joined with larger hospital organizations so that you can go into the little hospital down in Lincoln County and be identified as at risk, and they refer you to their sister hospital for
Right.
the specialized care that they have not had the ability or the depth of staffing to do. So it can work both ways, but I always fear the lack of
Yeah.
access.
The link is there, it's just redefined.
I know
Yeah.
in this
Yeah.
general community, although it's not in the Biddeford community, but Goodall Hospital
Yeah.
in Sanford, it's become part of Maine Health, Maine Healthcare, and there's been some concern about that function being altered in large degree.
And I think something like working towards zero suicide, it's like a shameless plug, and I do apologize, but it does feel appropriate, fitting. That concept is something that could in fact work with what you're saying, because those folks aren't going to go away. They're still going to be within those communities, just like Lincoln County. And so something like working towards zero suicide isn't just a standalone at a hospital or a practice. It is community-based. So bringing this in and working very methodically and step by step toward making folks feel comfortable, be it the receptionist from the moment you say hello to being screened and seen, and having everybody have a level of understanding and confidence in what their role is, and then having the link to the what ifs. What if that receptionist, when you walk in and the receptionist immediately thinks, we're in trouble here,
Yeah.
Upon hello, we've got a crisis. What do I do? So I think that whole working towards zero, I know that sounds big thinking. That concept and philosophy is something that can work in these situations, but it's not a quick fix.
Right.
It is shifting thinking and shifting a level of comfort that's been there and a way of doing things and billing and all that. Which leads me to a question finally. So having these successes that you're feeling, that moving in the right directions, what would be some of the recommendations you would make for a hospital or a primary care practice or whatever, a healthcare organization, be it 10 people or several hundred people, would you give as far as the whole concept of working towards zero suicide?
You want to tackle that first?
Well,
Patients being one, and not
Right.
patients as in people, but patients for the process.
Patience for the process, I think buy-in from leadership. I think having a couple of champions at different levels of the organization, commitment to the goal. That's what I got. What do you got?
Yeah, and I think one of the critical pieces, which we haven't really talked about, is how do you make sure that the different levels, which are people at different levels of your system, can and do talk with each other and communicate.
Collaboration.
That's a huge piece. Communication, Maine is a small town, as they say, and relationships are driven. So part of that is communication through a coordinated health record. And boy, we're still struggling with that, incredibly so. And part of it is communication with people. And the third piece I want to add to this, which we haven't brought in, so far we're talking about professional systems of healthcare, but how do you make sure we're also listening to family members and community members? Right. And how do we ensure that they know what they're doing? Just like, the foundation of this program, Maine Suicide Prevention Program, is that suicide is up to all of us, the prevention of it. How do we make sure that we have ease of access to the information that family members have, and that they are empowered to both know the system and respond to it? And that's one of the things that NAMI does around the state, is offering education, support, and really advocacy for people to understand and work with the system of care, including medical and behavioral health. Yeah.
And I'm assuming the families and loved ones play a role in the care within Sweetser as well.
They do, absolutely. I think there have been times when I've been frustrated with HIPAA and the response of professionals to, well, I can't share, I can't work with you around those concerns. It's a struggle sometimes to find the middle ground to support staff, to support families. I think there are always ways to do that, to help people.
Are there types of trainings that you feel, as far as with the working towards zero suicide, what are the kinds of trainings that you feel would be of benefit at the outset and maybe as refreshers?
Well, at the outset, and where I try and get people to start, is really at that administrative leadership level, getting the buy-in and getting the thinking in place that designs the system, both how we respond and how people communicate, what their roles are. So those protocols, that's really important. And then kind of as two tracks, the training, which is basic awareness level training for everybody, so that everybody kind of knows where they can put their finger in the dike, so to speak, in terms of saying, if I'm concerned about somebody, who do I send them to? And then professional level training so that there's really good skills at assessment and management of suicide risk, which includes treatment of depression and anxiety, clear risk assessment and appropriate referrals. So training around that, and then training to make sure that there's a system in place for tracking and follow-up. Yeah.
Yeah, I would agree with all of that. I think that we've done two different tracks of training, one for clinical staff, one for non-clinical staff. I think it's important to make sure that everyone gets that training and gets refreshers annually. So we are doing ours annually. I think a regular check-in, how will we continue to keep this current and fresh? and then look at data. I think one of the difficulties around gathering mental health data sometimes is that it's easier, not you can only, but it's much easier to track negative data.
Right.
And so
Right.
to figure out the number of suicides you may have prevented is only pretty much anecdotal. I mean, you can't,
Yeah.
It's a guessing game.
it's a guessing game. I mean, sometimes if people don't complete a suicide and then are attempt free over a certain amount of time, maybe.
Right.
But I think gathering data has always been, we've seen a reduction in this number, not necessarily we've prevented.
Right,
Prevention
right.
data is always a
Oh,
moving target. So I think that's,
I've known that for 20 years.
right, I know you
Data's another
know.
one of those four-letter
Four-letter
words.
words,
That's
thank
what-
you.
So I think that's a challenge
Mm-hmm.
sometimes to say we can show a reduction, but we can't really show prevention accurately.
I think one of the
So important.
one of the big things I think that I've seen across the board is you are able to demonstrate, for the want of a better word, an increased level of confidence
Right,
in staff.
right, at all levels of the
Right.
organization.
I mean, because again, that assumption that, well, if you've got 98 initials after your name or this or that, you should be able to do this. And it's not as easy as that. It's very complex. And again, as I've said a million times here, I'm so pleased with the level of confidence that NAMI's able to literally demonstrate to us in their post surveys of trainings. People are coming in saying, please don't make me do this, and I'm paraphrasing, I better understand it, I feel more confident, and I would in fact intervene if I felt it necessary. That's huge. That's huge. And I think the same can be said for Sweetser. It's just time, but we're thrilled. We're very fortunate in this state.
When you're speaking about confidence and people within an organization, my sense is that the confidence is something that is infused into the organization by the leadership. And if the leadership exhibits confidence in the people that they're leading, most people will respond very positively. And they will do whatever they need to do in order to live up to fulfill that confidence level.
I think certainly if they're involved, if they're kept, if it's not this, you shall do this. It's more of, here's how can we do this, and doing it together. Yes.
Question for you, Catherine. Takeaway. What we've discussed today, what do you wish that people would take away from this conversation today?
I think that Sweetser and NAMI's work has demonstrated that with time and patience and inclusion and communication, that the concept, in this case, working towards zero suicide, can in fact be integrated into a very large systems. Can it be done overnight? No. Can it be done single-handedly? No. These two agencies have clearly demonstrated that, again, with patience and knowledge and time, good things can be integrated into very complex systems successfully. So give it a try.
Greg?
I think we've really shown that there are processes you can follow to identify and manage someone who's at suicidal risk. I think my final word would be, still where we need more work on a social level is making it okay for people to say, I'm really in pain and I'm hopeless here and I'm at risk, so that people say ouch and ask for help, whether that's through the mechanism of a family member or on their own. That's another component we need to factor in here. And I hope that's changing.
And I would
Jamie?
just like to add to that, I think that my hope would be that people learn to see that depression doesn't have to be or isn't a terminal illness. That it can be, there are interventions that work just as they have put energy and money and resources into cancer research. I think depression and mental illness don't have to be terminal.
Well, from my perspective, today's show is kind of like the exclamation point to the series of shows that we've had. And going into these shows, I was lacking of awareness, lacking of knowledge, lacking of the seriousness of the issue, the depth of the issue. I'm not saying that I am where I should be now. I'm probably still lacking in a lot of those areas. But I will say that I am much more aware of the issue. All of the workings of the issue, I'm still very, very much a neophyte. But my takeaway is that talking about suicide is probably a depressing thing to talk about. What I will say is one of the things that I've learned over the past 5 weeks is that we have an incredible number of people out there trying to make good things happen, trying to have a positive impact, trying to get people involved and aware. And that can do nothing but help the situation. And where people can be most beneficial, you might say, especially in the society that we live in today, which is a very complex society. One of the things that drives me nuts in our society today is that we seem to be on a soundbite society, where we'll take a statement and we'll parcel it out and parse it up to find those 2 or 3 words that support our argument, and we'll lash out at them in order to make one's point. Well, lashing out at something is not necessarily going to help, and it certainly can hurt. And one of the points that I made early on in this series was, be careful of the words that you use. You may never get the opportunity to apologize for them. And I would make that same point today. We are, in a very real sense, our brother's keeper, and we need to maintain contact, maintain in whatever level of influence you might have, in a positive sense. And be concerned, be aware, be concerned, and mind what you say. Don't speak out of anger, don't speak out of frustration. Coach your words very carefully. And again, you may never get the opportunity to apologize. And that's an important thing to remember. And I am blown away by the level of dedication of the healthcare professionals such as yourself to tackling this problem, and that this takes what could be a very depressing subject and makes it a enlightening subject, makes it a subject that you're eager to learn more about, because the more you learn, the bigger the impact you're going to have. And with that, I want to thank
Thank you. I
Catherine?
appreciate the time. Yep, we're very lucky.
very
My
nice
pleasure
to
to
meet
be
you.
here.
Whoa,
Oops.
the MS kicking in again.
Yeah.
Very nice to meet you.
Nice to meet you.
And folks, that's it. And I close this show somewhat regretfully because I'm not going to have a Dynamite co-host anymore for a while. But Catherine, you did a splendid job. You made my job that much easier.
Oh, bless your heart. Thank you.
And I'm always for making my job easier. Folks, have yourselves a great remainder of the day, and make it a safe one. And bear in mind, you do have an impact. Make it a positive one. Have a great day. Bye-bye.